Hello, and a very warm welcome to COVID-19 Updates from Singapore. My name is Caitlin Wee, and I am a second-year medical student at NUS Yong Lu Lin School of Medicine. This webinar is the fifth in a series of 12, presented by NUS Yong Lu Lin School of Medicine, National University Health System, and Global Outbreak Alert and Response Network. This weekly webinar series will provide viewpoints and insights from a panel of leading experts in infectious diseases and related specialties and disciplines. It is now my pleasure to introduce you to our moderator, who is also the program director of the series. Recruited to establish an infectious disease training program in Singapore, he was the first infectious diseases head of department at the Communicable Disease Center here in 1992. He is also a visiting senior fellow of the Courage Fund at the university. Ladies and gentlemen, Dr. David Allen.
Thank you, Caitlin. Good evening and happy Vesak Day. Welcome to the fifth installment of our webinar, COVID-19 Updates from Singapore. We hope the broadcast continues to find you and your loved ones safe and well. As a reminder, each episode includes regional and international epidemiology review by Professor Dale Fisher, followed by an in-depth talk by our visiting guest expert. Question and answer period will follow with Professor Fisher, myself, and the guest speaker as panelists. Then we'll have a review of this episode's key points and current events by Dale, and then we'll end with a preview of next week's guest expert. We do welcome your questions and we welcome your comments of how we can serve you better. Without further ado, it's my pleasure to introduce Dale Fisher, who will begin our first episode. He's Professor of Medicine, National University Singapore, Yong Lu Lin School of Medicine, Senior Consultant, Division of Infectious Disease, National University Hospital, and Chair of the Global Outbreak Alert and Response Network, hosted by World Health Organization. Dale, over to you.
Thanks, David. Just let me share my screen. So, as usual, we're looking at the EPI updates from around the world. I'll start with the usual Johns Hopkins University dashboard, which continues to show I put these graphs a week apart. So in the last week, we've gone up another 500,000 or 600,000 cases. So this has been the trend very much over the last month or two. Deaths likewise around 35,000, 40,000. So to look at the global epi curve of this, one other piece of news through the week was that UK overtook Italy and became the second, sadly the second highest death toll in the world and the highest in Europe. So this is showing the graph of China early on and then how it spread around the world. This again, like I mentioned, is clearly flat, with around 6,000 to 8,000 deaths per day. And this is 6,000 to 8,000 deaths per day and around 70,000 cases all up. So to look at each region, so we've got Wipro, the Western Pacific region. Just excuse these anomalies. This was when extra cases were added in based on CT scans, but this is China and now remains very low. And this was the spike in deaths when they reviewed all the data and went to correct it. So that's what the Wipro curve looks like. Southeast Asian region is quite a different shape with increasing numbers and with that deaths. Do have a look at the y-axis, the number of cases in the region and the number of deaths in the region. It's mainly driven at the moment by India, which is somewhat disappointing because they are in a lockdown at the moment, but they're still getting a lot of cases. So in the last week, they've gone up 18,000, Bangladesh likewise, Indonesia. So these countries are really pushing along their numbers. Euro, as we know, they're coming down. So their R naught overall is less than 1. Although you can see with the black line being quite high, tells you the under ascertainment of cases. If you've got 4,000 deaths and 40,000 cases, we don't really think there were there were 10% of deaths. So that explains that, and all in future graphs. But you could actually see it's quite heterogeneous throughout Europe. The percentage increases are really quite small. So Russia is really driving it, and to a lesser extent, UK. This is the Eastern Mediterranean region. Again, got its own epicurve shape with increasing numbers, around 6,000 or 6,000 cases a day, with the deaths down around 100 across the region. But as we know, every country is different, with Iran coming down, although they've had a little blip up over the last few days. Saudi Arabia is really having large numbers now at 1,500 a day. And you can see the other countries with where they can't even report every day, so they look a little bit erratic. The African region, again, slowly climbing up, 1,400 cases a day now, but the death rate still recognised as apparently low. This is the Pan-American region. So this is excluding USA, just to make it a bit clearer. So a similar shape to some of the other graphs. And this is the African region likewise. So Africa is being driven by South Africa. Nigeria is coming along now, but again, the numbers are small, consistent with under ascertainment. So I think this is important to just keep remembering that every region has got its own epicurve, every country has its own epicurve, and every part of every country has its own epicurve. So this is what we're all familiar with in Singapore now, is that as these numbers are rising, it's really the dorm residents are the main source of cases. Imported, as we go down here, imported cases very occasional now. Community cases, we're having many days of just single figures, which is why the government's increasingly comfortable to ease some of the social restrictions in a phased approach. This red one down the bottom is the dorm residents, and it's quite flat. This could be good. It's partly capacity. The volumes of people in the dormitories really is extreme, in the order of hundreds of thousands. So just how many people can be out there to do the swabs, how many swabs we can do, what's our capacity. But there is a general feeling of optimism that maybe the number of ARI presentations are slowing down, but it's going to be a long road and take some pretty clever strategies that are being talked about at the moment. This is one of the strategies. You can see these in-care facilities, and how over the last 2 weeks they've really skyrocketed from. So these are community isolation facilities, community care facilities, where we can where we keep infected men, anyone infected, but obviously a large number of these are the dormitory men now. The pressure on the hospitals seems to be waning because we're getting the isolation facilities up. So if you work in a hospital, you might be feeling that the pressure on beds has gone down a little bit, but I accept it's only a little bit still. And the number of ICUs, far from being overwhelmed, that's still well under control. 20 deaths as of now, which gives us a case fatality rate of 0.1% at this stage. So that's a bit of an update, David. I'll hand back to you now. See you later in the show.
Great. Thanks, Dale. I'm wondering about how many countries have actually eased travel restrictions other than Australia and New Zealand, or at least talking about amongst themselves.
Yeah, I've heard of no one that's eased travel restrictions. I think the New Zealand rugby team has got an exemption, but you can still travel. You just have to be in quarantine for 2 weeks when you get there. But there's so many countries with low prevalence or low incidence of cases, it's a natural discussion. I think we mentioned last week, Singapore and China really could do this, and Hong Kong, Taiwan. But I think there's some reservation in what does a plane look like. Are we allowed? It's very hard to practice social distancing in economy, for instance. What's the mask wearing rules? And if there is an outbreak in a country, are we going to wind them back up? Wind the travel restrictions back. So I would imagine that, I'm not privy to these conversations, but I would imagine that's along the lines of what people are discussing.
There's an interesting scenario in the States. One of the airlines, Frontier Airlines, I believe, if you pay extra money, that they will make sure that you're socially distanced. If you don't pay extra money, you get to sit next to somebody. Very nice. All right. Thanks so much.
That's called first class, isn't it?
No, this is an economy. It's like $39 extra.
Oh, okay. Thanks
so much, Dale. We'll get back to you. I want to remind our listeners and our watchers to please send in your questions. There's a tab at the bottom and at the toolkit for the Zoom that allows you to do so. And we'd appreciate those questions. So we'll move on, and it gives me great pleasure to introduce our guest expert, Professor Alex Cook. He's Vice Dean of Research and Domain Leader of Biostatistics and Modeling at National University Singapore Swee Hock School of Public Health. He works on infectious disease modeling and statistics, including dengue, influenza, and other respiratory pathogens, and on modeling of populations to assess the effect of evolving demographics on non-communicable diseases such as diabetes. Professor Cook's title of his talk this evening is Modeling the COVID-19 Outbreak in Singapore, Science Fact or Science Fiction? Over to you, Prof.
Okay, thank you very much, David. So it's a great honor to be here and giving this presentation to you all. I don't think that ever in my career have mathematical modelers been quite so much in the news as they are today. But what is mathematical modeling? What kind of role does it really have in the area of public health? Should we be listening to mathematics and formulating the policies that we have to try to control epidemics? Now, I am a mathematical modeler, and I realize that most people in the audience are not. And may have a bit of a fear of mathematics. So I promise I'm only going to have 4 equations in total during the whole of the talk. So it should be relatively straightforward, and I'm aiming at the layman. So let's go into what is mathematical modeling. Actually, it's not something that's got a very short history. We've been doing mathematical modeling for infectious diseases for a very long time. If you go back over 100 years to 1915, there's a paper in Volume 1 of the British Medical Journal by Ronald Ross. You may know Ronald Ross as being the first British man to win a Nobel Prize for medicine. He discovered the parasite for malaria in one of the mosquito species. But actually, although he won a Nobel Prize, he thought that the proudest achievement of his career was actually developing the field of mathematical modeling, or bathymetry as he called it. And so I'm told that even further back to the time of which Jenner was developing the smallpox vaccine in the first place, that people were already thinking about how can we use mathematics to try to understand how we should intervene to try to prevent transmission of diseases. So I'm going to be starting by giving you a little bit of an introduction about the most fundamental constant in mathematical modeling of infectious diseases. It's called the reproduction number. And I think you probably heard about it because it's been starting to appear in some of the media articles about how transmissible the virus is. So the basic reproduction number is the fundamental quantity of mathematical epidemiology. It quantifies the transmissibility of pathogens. To understand how transmissible a virus is, I'd like you to imagine that you're infected by that virus. Let's say it's SARS-CoV. And I want to find out how many people you're going to infect over the time period that you are infectious for. So either until you recover or until you pass away. So let's assume for this that you know N people in your social network, and you come into contact with some of them, a proportion of them C, while you are in that infectious period. Now, for each person you come into contact with, you're not going to infect all of them, right? You'll infect some of them. So let's say there's a probability V that you infect an individual you come into contact with. And then every time that you are trying to infect that person, there's a probability that they actually get infected by the virus. Let's say that's H. So my question to you then is, how many people would you infect on average? Right? And so this is quite simple mathematics, right? You've got n people you come into contact with, a fraction of them you actually come into contact with during the period you're infectious, a fraction of them you try to infect, and a fraction of them you're able to infect. So this total product is what we call the basic reproduction number. So it's called R naught, and it has a similar kind of a property as the fertility rate in human populations. It tells you how transmissible the virus is. Now, I've color-coded the different quantities there because I wanted to illustrate that actually this is not just a purely biological measurement, right? Some parts of it are biological. The probability that you will get infected if you're challenged by another host, that's a biological property of you and the virus. But the part I've put in blue, these are more social features. These are things that we can possibly try to modify in order to reduce transmissibility. Now, the reason why the reproduction number is so important is because it characterizes the transmissibility of a virus. We think about the following 3 viruses here. Which of them is the most transmissible, and how much more transmissible are they than other viruses? Do you know? Well, I'm ordering them by transmissibility. Measles is the most transmissible of the 3 that I showed you, followed by Zika virus in many populations, and followed by Ebola. Now, some smart buggers have tried to work out how transmissible each of these are and quantify the reproduction number for the 3 different pathogens, and are tabulated in this little table here. Importantly, the reproduction number is not the severity of the virus, right? So R naught doesn't quantify how severe the virus is or severe the epidemic is. But in fact, the impact of the epidemic is a product of both how transmissible it is as well as how severe it's going to be. I think most of us would much rather get infected by Zika or measles than to be infected by Ebola if we had the choice. Now, reproduction number has a nice threshold property in that it determines whether a pathogen can be maintained in a population. So if the reproduction number is 2, as it is for Zika, as it may be for COVID, then if you have at generation 1, 10 cases, then by generation 2 you have 20, generation 3 you have 40, then you've got 80, and so on. In other words, you have this growth, which is an exponential growth, because each time you're multiplying how big the number of infections are. If the reproduction number is less than 1, let's say it's a half, then you start off with 10 cases and they infect 5 people before they recover. And those 5 people infect maybe 2 or 3 people, and those 2 people infect 1 person, and then it's all over. So there's this kind of a threshold where the virus is able to reproduce in the population. That threshold is 1. So above 1, then you're able to get epidemics. Below 1, no epidemic can be self-sustaining because it's just going to be dropping down over time. Now, from this very simple model, we end up with something like an exponential growth, which you've heard about through the media quite a bit. The exponential growths are very difficult intuitively to understand because from our day-to-day existence, they don't exist in normal times. Right? We're used to things like linear growth. Things grow in a small way that we can appreciate more easily. So I'm showing here what would happen if you have a reproduction number of 2. You start off with 1 infection in the first generation. Then by 10 generations in, you'll have about 1,000 infections. Question, how long will it be until everyone gets infected, do you think? How many generations of infection? Would it be maybe as many as 1,000? Probably not. Maybe as much as 100? So let me zoom out a little bit and I'll show you how many generations it takes to, go back a bit, to get to pretty much everyone in the population infected. And it's surprisingly few, and that's because of the exponential growth. So if the reproduction number really is 2, then, and we're not doing anything to try to prevent transmission, then by 25 generations in, not quite everyone, but the vast majority of the population would have been infected already. Okay. Now, why doesn't everyone get infected? So I put 5 million people into this model. Why not all 5 million get infected? Well, later on in the epidemic, if let's say I'm infected in the second half of the epidemic after the peak, many of the people that I'm coming into contact with have already been infected, and so they're not going to get infected again. And so many of my infections have kind of wasted in that sense. And that's where you have a kind of tapering off. So the exponential growth only applies in the early period of the epidemic. Now, one of the reasons why it's quite difficult to understand this, because if you look at this exponential growth, the first, let's say, 15 generations, you can hardly see because they're so close to the axis, because in comparison to the total epidemic size, they're so small. That's one of the reasons why we'll often plot exponential growth using a logarithmic scale. So you've seen these a lot in media articles, where they will show different countries against each other on this kind of logistic scale, a logarithmic scale. And the reason for this is that it allows you actually to see how the growth changes from one generation to the next generation. So I'm not sure if I'm able to zoom in here. Yeah. So you can see that maybe after 10 generations, you have 1,000 people infected. After 15 generations, it's popped up. It's well over 10,000 people infected. And that's something that you're able to pull out when you look at this kind of logarithmic growth. Okay. Now, one of the really nice things about understanding the reproduction number is that it actually tells us at the very beginning of an epidemic how large that epidemic is going to be if we don't do anything to try to stop it. So how big will an outbreak be? So I've calculated those curves for the 3 different pathogens that we spoke about earlier, and I've plotted them R0 on the y and x-axis, and then the final proportion of the population who get infected on the y-axis. I've cheated a little bit when I did this because I can't fit R0 of 18 onto the chart. So I'm just pretending for a second that measles has got R0 of 5. Right? Then you can take a look through these points, and actually you see that they look like they're following some kind of a curve there. So the second of the 4 equations that I'm going to show you, the first was one of Rossi's equations, is that someone has worked out what the relationship is between the reproduction number, R0, and the final attack size of the epidemic, F. And we can plot that. It looks like this. Okay. Now, the important thing about this is it doesn't just tell us how bad an epidemic is going to be at the very beginning of the epidemic, but it also tells us what we need to do in order to prevent that epidemic from happening. So if you can estimate the reproduction number early on, and there's lots of ways that we can do this, then that can tell us later on how many people will get infected in total. Now, it tells us how many people, or how much we need to change the reproduction number by if we are going to have any chance to prevent the epidemic. So how can we change reproduction number? Well, we've got that social part of the formula I showed earlier. That is one of the ways that we can try to do that. So we can implement physical distancing, people working from home or school closures, etc. And that will have the impact of reducing the reproduction number and then moving the final attack size to the left. And you end up with a smaller number of people being infected. So imagine if you could reduce the reproduction number by 1/3, right, by reducing 1/3 of the contacts that you have, or that people in the population have. Then the impact is that for something like Zika with a reproduction number of 2, you're able to reduce the number of infections from around about 80% of the population down to around about 40 to 50% of the population being infected. So about halving of the total infection size. So you reduce contacts by 1/3, but you have the number of people who get infected. And look what happens to Ebola. If you're able to reduce the reproduction number by 1/3 for Ebola, you have no epidemic anymore. Right? You've gone from something that infects 60% of the hosts down to something that infects no one. Right? And so that gives you a threshold that you have to try to achieve if you're going to prevent transmission in the community. Okay, so for a virus which has reproduction number of 2, which is what we think that the COVID virus has, then you need to reduce transmissibility by 50% if you're going to prevent epidemics. Okay. All right. So how big will an outbreak be? That was the question I was looking at just there. What I thought I would do is I'd show you how big it's going to be under different scenarios in which we're able to reduce the reproduction number, because that gives us a bit of a way to understand why we implement the circuit breaker measures, why we implement it for as long as we do, and what needs to happen after a circuit breaker. Okay? So for this simulation from a very simple mathematical model, I'm assuming that the reproduction number is constant over time at a level of 2, which is probably what it was in the early period of the epidemic in Wuhan, for example, and maybe what it is in the dorms in Singapore. So I'm looking at a population of size 5 million, and I'm projecting forward in time, starting off with maybe 100 cases way back in February. How will the epidemic spread under this idealistic scenario? And if it's left unabated, then you would expect that we'd have a peak somewhere about July or August, maybe National Day. And at that point, you'd have about 30,000 people being infected every day. Right? That would be a fairly disastrous outcome. Now, if we implement a period of circuit breaker where we're reducing the reproduction number from 2 down to maybe 0.8, for example. So if contacts go down by, my maths fails me, what's that, 60%? Down to 0.8. But only for the period of the circuit breaker, and then we relax and we go back to life as normal after circuit breaker ends at the beginning of June. Then what's going to happen is we're going to see an epidemic of the same size and the same duration, but just pushed further back in time by a little bit over 2 months. In other words, the duration of the circuit breaker measures itself. So this approach is not going to reduce the overall number of infections at all. We're going to have the same size epidemic, same number of deaths, same number of people in ICU, etc. But all we're doing is we're pushing it back further, buying a little bit of time. Okay. What if we have staggered? We have a circuit breaker, then we have a circuit breaker again later, right? So let's say we don't want to have a big outbreak in August, so we put in circuit breaker for the duration of August. How will that change epidemic? Well, this epidemic size is actually very similar. Maybe it's a little bit smaller, a little bit more peaked around about the time of the peak, but overall the same numbers of people are basically getting infected. The area under the curve is around about the same. And so the reason is because during the period in which we don't have circuit breaker measures, it is able to spread as rampantly as it was way back in the beginning or in the unmitigated scenario. So that is clearly not the approach that we need to take. It doesn't matter really how long we make that second subsequent circuit breaker intervention. You're basically just pushing back further and further the epidemic, and maybe ever so slightly, the longer you can keep on circuit breaker alternating between on and off, then slightly pull down the size of the epidemic, but not by much. Okay. So this kind of an approach is not going to have the desired effect. What we need to do is to move towards something which I'm labeling here sustainable distancing. So after circuit breaker ends around about start of June, that we move to a scenario in which the reproduction number may not be as low as it is just now. So we relax the measures to some degree, but it's not as high as it would have been back if we're all just having life completely as normal. And if that's the case, you can hardly even see the epidemic that results. It's actually there. If you look very closely, there's a little bit of a black line just at the end of December, but it's very difficult to see it. Right? So this would have the effect of bringing down transmission in the short term and then keeping it at low levels. It doesn't matter whether we make it, let's say, reproduction number 1.2, 1.3, or 1.1. Anything around about that level is going to drag out and flatten the curve for a longer period of time. Another strategy that we can take, which interests me because I think it's very nice from a mathematical perspective, is you could let the epidemic go until it gets to around about the time of the peak, maybe a little bit before the peak, and then you go in for one last burst of circuit breaker measures to bring down the epidemic quite rapidly and then reach a level of herd immunity earlier than when the epidemic would otherwise have let you get to. So I showed you a formula for the final attack size. That's the final attack size for an outbreak in which you let it go up to herd immunity and then keep on coming down until it gets back down to zero. So more people get infected over the duration of that epidemic than would be the case if you're able to get to herd immunity at point of zero. So you get down perfectly to no infections at the time at which you reach herd immunity. Now, I'm going to ask your forgiveness, and I'm going to show you those charts again, but on a logarithmic scale, because I think that gives you a better way to visualize how the interventions are having an effect. So an unmitigated epidemic on a log scale looks something like a triangle, like this. If we implement circuit breaker for just 2 months, you bring down the number of infections for a while, but then the slope goes back up to be exactly the same as what it would have been, just offset by that time, like I told you before, by about 2 months. If we have another circuit breaker, for example, in August, it's a similar kind of an impact. You end up basically just staggering the period at which you're having those periods of exponential growth, which appear linear on a log scale. If you move towards sustainable distancing, then what will happen is you'll still get a growth, potentially, if you have reproduction number above 1, but it will be at such a low level that the healthcare system should be able to handle. It should be able to have enough resources to be able to deal with the numbers of cases that you get. If you can keep this going for long enough, then you'll end up reaching the point at which a vaccine becomes available. And the final indulgence I'm going to beg of you, I'm going to show you the cumulative number of cases, because I think this is important for illustrating that if you implement circuit breaker and nothing else, and you go back to life as normal, the same number of people will get infected, regardless of what you do about the circuit breakers. So in other words, what you need to do is to move towards something where there is a kind of a sustainable social distancing for some period of time, or to calm down hard just before the peak happens, so that you will end that first wave of the epidemic with around about 50% of the population infected. So that's one of the things that we do mathematical modeling for. So it's to try to understand how much of an impact we need to have with the interventions that we implement. But the other is to try to assess what the impact of those policy options would be if we look at specific policy options. So on the previous slides, I said, let's imagine we can somehow make the reproduction number go down from 2 to 0.8, but without saying what would be involved in so doing. So, for example, school closure is one of the policies a lot of countries have implemented, but the model that I used in the previous set of slides doesn't have schools in it. It's just assuming that everyone's mixing around homogeneously. There's everyone of the same age group. So if we want to try to assess what the impact of something like school closure would be for workplace distancing, then we need to have a model which is more sophisticated, accounts for schools, accounts for workplaces. And so the way that we do this is by building something called an individual-based model. This is a model which represents the population, possibly spread out over space, at least spread out over social space. So we developed an individual-based model, an agent-based model, actually following the last pandemic, the influenza pandemic, H1N1, 2009, and then updated the parameters for this so that it looks like what we thought COVID would look like based on the earliest epidemiological data that we could get that was coming out of China. We've refined those assumptions as we've gone forward in time. So this it uses a large amount of different data sources. We run it on our supercomputer in the school for days on end in order to simulate what would happen if we were to look at different kinds of interventions. I'm going to show you very briefly, in a couple of minutes I've got left, some of the kind of interventions that we look at. So for example, if we were comparing doing nothing in blue to implementing quarantine, having workplace distancing or school closure, or combining all of those measures at the early period of the epidemic, so before things were really taking off, then we can see that actually you'd have a huge reduction in the number of cases over a period of weeks to months at the beginning of the epidemic, or alternatively, that we would push back the time at which we get broad-scale community transmission by several months. That would buy us time to ramp up the ICU capacity, to make sure we've got enough PPE for all our doctors, keep Dale safe, for example. We also have been looking at where we should be isolating our cases. So one of the fundamental differences between the Asian approach and then the European approach to controlling the epidemic seems to be that in Asia, our cases are being isolated away from home. So for example, I think the Chinese call it like a Fangchang hospital or something. So basically a community isolation facility. Whereas in Europe, it seems the norm to isolate milder COVID patients at home, where of course they're able to infect their families. That's another of the kind of things that we're able to explore by doing this kind of individual-based model. So at the beginning, I had this controversial statement, is modeling science fact versus science fiction? I haven't really addressed that. I thought it would be worth spending just a couple of my last minutes talking about that. I think that modeling is in a way both science fact and science fiction. It's science fact because it is grounded in our scientific and epidemiological understanding of both the pathogens, society, and how diseases spread within a society. It's no secret that most of the best modeling groups are based not in mathematics departments or engineering faculties, but they're based in schools of public health or schools of medicine, where there's a strong interaction between doctors and epidemiologists, mathematical modelers. That's what brings kind of a realism and common sense to the kind of models that we build. It's also science fiction in the way that models, all models, are not reality, they're models of reality, they're approximations to reality. So in the same way that a mouse model for a human is not a perfect reflection of how we're going to respond to a drug, for example, so is a mathematical model of an epidemic not a perfect representation of how the epidemic will progress over time. So we hope that it's good enough. We hope that the drug that we develop in the mice, when we apply it to man, will have the same effect. We hope that the interventions that we run in silico in a mathematical model will have the same kind of effect in real life. But of course, the proof of the pudding is in the eating. So we'll be able to assess some of the policies that are being implemented afterwards with the benefit of hindsight. But right now, when we're making decisions, we've got to go with whatever we can. And mathematical modeling is one of the best ways to try to do that. So I've mentioned a couple of papers in the individual-based model. You can scan the QR codes. It'll take you through to the web pages. These were at Lancet Infectious Diseases and Lancet. I would like to thank the people who make my work possible. So I got funding support from the School of Public Health, from SPHERIC, which is our Population Health Improvement Centre in NUHS, and a grant from NMRC to study COVID modelling. I also want to thank the people who actually did all of the work, because I'm just using my high power most of the time. Finally, thank you, and I hope you have a good VSAC day. Thank you. Over to you, David.
Great. Thanks, Alex. That was both awesome and sobering. And I'm going to take the moderator's prerogative and ask you a question first. What is sustainable distancing?
It's a term that I made up this morning.
Oh,
preparing my slides.
Because I'm trying to imagine what it would be.
So it's a fundamental question. What do we need to do in order to bring down contacts between individuals to a level by which disease is either not, transmission is not sustainable, or it's sustainable only at low levels, at a level that we can tolerate, and therefore not overwhelm the ICU capacity. So there's various measures which, of course, are being implemented just now. The circuit breaker, I believe, has been, if you exclude the dorms, the circuit breaker has been a great success. At the beginning of circuit breaker, we had quite a lot of community transmission in the general community, so excluding the foreign workers. That has really dropped down to quite low levels. As Dale mentioned, single figures some days, sometimes low double digits on other days. So that suggests that the measures that we've implemented just now are maybe more than what we need to have when we move beyond that first period of circuit breakers. We brought it down to a low level, but we can afford to relax some of the measures. And I think actually that's something that the government's already started to do, like opening cake shops, etc. So moving out of the circuit breaker, I think that we'll still need to have some kinds of social distancing in place. I don't know exactly what form it will take, but my guess is that probably schools will reopen, because it's quite of an inconvenience to the school kids for not getting their education, and it has secondary impacts on working families that are not able to go to work because they've got to look after the kids. The number of people who have complained about home-based learning, supervising home-based learning of their kids has been, to me, in the chat groups, has been quite unbelievable. I suspect that for workplaces in which social distancing can be maintained, so like working from home, for example, so a lot of white-collar industries, I suspect that we may still have employers choosing to have employees working from home where they're able to, or maybe alternating. So like in the School of Public Health, even before circuit breaker started, we were alternating. So we had team A and team B. Some people stay at home, some people come into the office. I think that's the sort of level that we may need to maintain if we're to keep the amount of reproduction number to just above 1 or not much above 1, just a little bit, or at 1 or a little bit above.
Great, thanks. Appreciate that. Now we'll move formally to our question and answer period, and the panelists will be Dale, Alex, and myself. Caitlin, do you have a question for us?
Yes, Dr. Allen. Our first question tonight is, you mentioned the total number of cases in Singapore could hit 30,000 or 40,000 this month. Could you share with us and the audience how you arrived at this number using mathematical modeling? And can modeling tell us when the numbers will start to taper off?
That's a very good question. So In a way, actually, the mathematical models of the epidemic in Singapore so far have not been as great as they might have been. So at the very beginning, we were expecting that the pandemic would evolve much as the influenza pandemic of 2009 evolved. So basically, a very standard-looking normal distribution. Now, what actually emerged is because government implemented quite strong measures at different phases of the epidemic, and we've experienced quite different epidemic behavior over time. So we had the initial wave of cases were mostly either imported from China or secondary transmissions from those imported cases. That got cut off when we cut off the border first to Wuhan or Hubei, and then secondary to the rest of China. Then we had this period where there was low levels of community transmission. Then we had a period where we had high levels of importations, mostly from Europe and North America, from basically Singaporeans returning from the worst affected countries overseas. This had a secondary wave, which was running in parallel to it, which is basically the shadow of that, the cases that were infected from returning Singaporeans returning home. Following that, we have the epidemic in the foreign workers in dorms. So we've gone through quite different behaviors, and some of those behaviors are actually very difficult to try to model a priori. So for instance, I would not have guessed the vast volume of numbers of cases coming back in from Europe, from like our Singaporean students coming back home from exchange, for example. That's something that a month before, the models were not thinking about. So we're thinking, okay, we've got this kind of local transmission, it's relatively under control, we don't have a lot of cases coming from China, etc. So at that period of the epidemic, the models were not forecasting what was going to happen next very well, because what happened next was not part of the universe in which the models were built for. Now, what's happening more recently is that we have a spread in the dorms, which initially behaved like a kind of an unmitigated epidemic. I know it's not the case now, because we're actually putting in quite strong control to try and bring it down. But in the early period of the dorm outbreaks, we had all of the hallmarks of an epidemic model. It looked exactly like an exponential growth going up and up and up and up. And so the earlier forecasts that we had made of around about 10 to 20,000 by the end of April, so that was based on fitting epidemic models to the early period of the dorm growths, and then projecting that forward in time until you got to the end of the month. And then you said, okay, well, that's how many cases there's going to be. Now, the problem is that now epidemic behavior is starting to change, because we've now got all of the community isolation facilities at Expo and Changi, and we're doing much more aggressive testing in some of the dorms, and that should have the effect of being able to separate out the infected and the susceptible cases, so that we can prevent transmission happening between those. What we can do is we can project forward from now to the end of the month, but what we're seeing is that the projection and the data are starting to diverge more and more the further forward that we make those projections. And so the reason for that is because we're not picking up all of the cases, because we're not testing all cases, we're testing just the ones that are, there's more uncertainty about whether they got COVID or not. And because we are intervening now to try to bring down transmission. So when we project forward, actually we have, from the model itself, we have far more than the number that I was quoted in the press. However, factoring in the reduced number of secondary cases that we seem to be having due to control, and the reduced number of tests, that's what led to the number of 30 to 40,000 infections.
Right. And the second question is, from your work on local modeling, do school closures add a significant boost to containment?
Yeah, that's a good question. So they do seem to, but, well, no, let me take that back. They do seem to have an effect. And the question is, how big an effect do they have? And that's a question which is being asked not just here, but by a lot of countries worldwide. We genuinely don't know what the effect of school closure is, because so many countries implemented it quite early on. Hong Kong, for example, I think from the very beginning, they were already having school closure. I believe even in China, because the epidemic kind of start of the epidemic coincided with the Lunar New Year. And so schools were closed anyway, and they just kept them closed after that. So we are in doubt as to exactly how much of an effect that there will be of school closure, partly because when we implement school closure, we don't just do school closure and nothing else. It's not like, when you do like a clinical trial of a drug versus placebo, you give the drug and you don't like mess it up by putting lots of other drugs into the mix, right? You try to keep it as clean as possible. That's it's not possible in real life with epidemics. You can implement lots of different things, slightly stagger at different time points, in order to just try to make whatever tweaks to the control that you're able to do. So I think that we're going to find out quite soon, because presumably schools are reopening when circuit breaker ends, and then we'll be able to start to get a bit better of a sense of actually how transmissible children are. Seems like the viral loads in kids are about the same as the viral loads in adults, but they get infected at a lower rate than adults do. So they're able to transmit. They have milder symptoms, but they're not as likely to get infected, and don't quite understand why that is the case.
And the third question is, how do modelers address the issue of data accuracy when the source's reliability may be in question?
That's a $1 million question. So especially in an emerging epidemic, data is always going to be not of the quality that you would like to have. An analogy to modeling epidemics is modeling the weather. So for over a century, people have been forecasting what the weather is going to be like. We've got so much ways that we can measure the weather that our models of the weather are actually really good. We can make quite good short-term forecasts of it. The problem is that when we have a new epidemic of a new virus, so many of the fundamental quantities are not really known. And so you borrow them from other places. Like we took the initial estimates of the reproduction number from estimates from China, and we said, well, maybe it will be the same in Singapore. And it doesn't seem like it is the case, because it seems like the reproduction has been at a lower rate, so roughly around about 1 actually, due to the kind of the contact tracing work that NOH does, and the fact that we're isolating our cases in the hospital at isolation facilities. So, so it is certainly true that a lot of the data is less ideal than what it would be, not through the fault of the people creating the data, but just because it's an emergency situation, people are cobbling together whatever solutions they can come up with. So the answer to the question, we make do with whatever we can, and then hope that the model results will not be too far off. Recalibrate over time. If it does look like the data and the model are inconsistent, then we recalibrate.
Right, back to you, Dr. Allen.
Great. One last question. You touched on this briefly, Alex, and that is there's some viral websites that are quite obviously popular, where the modelers are predicting that the epidemic will end on the 22nd of August at 3 in the afternoon. What are your thoughts about? They're very appealing to people, but what are your thoughts about that?
Oh, I've already picked my holiday. Yeah. So there's lots of models out there. There's some built by really credible groups. So, for example, Imperial in London, London School of Hygiene and Tropical Medicine, Harvard, etc. And so they have a long-standing track record of building realistic models that are informed by the epidemiology and which are used successfully by policymakers. But modeling, I mean, anyone can build a mathematical model. It's not that difficult. I mean, there's papers out there. You just look at what the equations are, you implement it on the computer. So anyone quantitative can do that. But if you don't have that kind of a training in infectious diseases, in the epidemiology of disease, then it means that you may not understand some of the nuances of the assumptions that go into the model. And so there's, like with everything, there's good science, there's bad science out there. There is good science, and the good science should not be tarnished by bad science.
Great. Thank you so much. We apologize to the audience. We have so many excellent questions and we only have a finite amount of time. We're going to move to the next section of our episode this evening, and Dale is going to talk about current events and key points from the evening. Over to you, Dale.
I wanted to talk about two things tonight that have sort of crossed my desk. The whole issue of testing and testing strategies and testing ratios, and I've come across a very interesting survey of global perceptions of how their countries have handled the response. So I think we've all seen this. Certainly when I was in China, that they were down around 1% of all the tests done were positive, and this is what people talk about, is you want a very low percentage of positive test rates to show that you're coping well and picking up as many as possible. You can see at the moment Singapore's about average. This was done 2 weeks ago, so I think we'd have a higher test rate through the dormitories in the last 2 weeks. Then you look up at the other countries, Brazil, France, Ecuador, Belgium, very, very high positive rates, and this suggests that they're really struggling to meet the demand. Here's a nice graphic that's come from a chap who I've had some interaction with now, Thomas Pueyo, and he's got some nice graphics if you want to go onto his website and have a look. And thanks, Thomas, for letting me use these. If you don't have many tests, then you're going to have a high rate. Obviously, for instance, in the dormitories, it's a hyper-endemic area. If you've got symptoms, it can be argued that there's no point in testing because the positivity rate is just so high. So then you need to get more strategic with your testing, and where is the best place to direct your resources. Obviously, in an ideal world, you'd be testing everybody, as some countries are managing to do, or even test everybody every week. That would be heavenly to try and control this, but that takes huge capacity. So in Singapore, we've swung a little bit more towards the nursing homes after some nursing home outbreaks, which are public knowledge. It's been decided to really do some sweeps of these, especially when we found some of the people, or many of the cases were actually asymptomatic or mild. So a lot of nursing home residents can't complain of it, can't complain of symptoms, or else they aspirate quite a bit, so they often cough and have some sputum. So this is a very challenging area, and these are some of our volunteers that are doing it. You can see on this one, some of the strategies are to do pooled testing, so you can do 5 at one. This is a good strategy in a low prevalence setting. And then obviously if this test comes back positive, you've got to go back to those 5 people to work out which one it was. But these are I think these are RHS workers going out in the evening, ready to set up for the campaign in the various nursing homes around the country. And this is an enhanced surveillance sweep to really try and make sure that there's no smouldering disease in a very high risk population, as opposed to the dormitories. Less high risk but hyper transmissible areas. Obviously much younger, much healthier men and very large numbers of people, as you know. But you can argue about the strategy in these dorms as well. Do you do high prevalence dorms? Do you do low prevalence dorms? And this is the strategic approach, which has been discussed as the best way to clear people and dormitories. This is some more graphics from Thomas, looking at cases that might be pre-symptomatic or symptomatic or transmitted through the environment or even from asymptomatic people, just with some estimates of the likely prevalence. And then a nice graphic showing that if this curve is the pre-symptomatic ones, then contact tracing is just so crucial, and many countries are doing their own apps and building up their contact tracing teams, because if you can find all the contacts of a case, and quarantine these people, or maybe even test these people, but certainly quarantine them, then that's how you break the chain of transmission. That's this one here. On this graph, however, these are the clinical cases, and the amount of time people spend with symptoms in the community before being tested and isolated, again, makes this the weak spot. So we've got two weak spots here, which really drive the response to include contact tracing, which has to be thorough and fast, and ramping up testing to get cases as early as possible, especially if they're symptomatic. So that was my little just thoughts on testing that I thought you might be wondering a little bit about, in terms of, you know, what are the strategies in terms of who to get tests when there's a limited resource. I just wanted to now talk about this. This was sent to me by David Black and Alex Hutton. Thank you for that. It's a nice little study that was done on 12,500 people across 23 countries. It was a fairly balanced group, fairly good statistical margin of error, and it was done during last month, a couple of weeks ago. It's a good age spread of the people that were surveyed, and equal male-female. So they wanted to assess the political leaders, the business leaders, the community, and the media, and how they had responded in the country. So Singaporeans were talking about how it worked in Singapore. Australians were talking about Australia. And the things that influence people were the preparation and the swiftness of the response, executing an action plan, and transparent and reliable communications. And obviously not doing those was a negative factor. Business leaders, they wanted some leadership to reduce the strain, but a lack of visibility, failing to take a hit themselves on executive salaries, and supporting workers through the time were all seen as expectations of business leaders. Community at large, how was the community behaving in terms of social distancing, looking after the elderly, and were the community leaders standing up? And then the media, was it accurate? Was it unspun? Were they filtering out the fake news? Were they giving accurate or inaccurate information? So it's a little bit blurry, but look at this one. It's political, then business, then community, then media. So these four boxes: political, business, community, media. China was ranked the highest by its citizens, who said that its political leaders did well, business leaders did well, community behaved, and the media was pretty spot on. Vietnam also did very well. India remarkably did well. Malaysia has a fair bit of confidence, but as we go down, here's Singapore. So only 41% of people thought that the political leaders performed. Obviously not very satisfied with the business response, the community response, but hats off to the media, they got a 92. So you can see all these countries, actually there's pretty much a fairly broad view. Look at Japan, that there's been an underperformance by many sectors of the community. So that was Asia. Now let's look at New Zealand. Pretty happy with their political leaders. Everyone's quite happy with the media, actually. And Australia, very similar to Singapore in terms of political response and business leaders. Generally, you can see the political response, but more so the business leaders are not doing the leadership that might be expected of them. US has got 32 and 27 and 66% for media. So that's one aspect. This is looking at it again. So how political leaders were rated. China, Vietnam, New Zealand, UAE, Malaysia, India and Taiwan were all above 50% approval. This I found quite interesting. South Korea and Hong Kong, both with very successful responses, are generally not looked on by the government as not looked. They're not they believe their government didn't do so well. And then there's all these ones in the middle, which are between 25 and 50, including Singapore and Australia. Looking at in 21 out of 23 countries, less than half the population thought that the business leaders responded well. Only in China and Vietnam did business leaders get a tick. Everyone else, and you can see all the red on this, that really the business leaders didn't, or at least so far haven't stood up. Looking at the media, it was, you saw there were very good numbers, but what media are people watching? Well, it's TV, radio, current affairs programs, newspapers. I'm quite shocked. Social media is down here at 31%. So people have gone back to, I guess, the traditional favourites for reliable sources of information. And then how have local communities performed? So again, China, Vietnam, UAE, India feel that their community as a whole has performed well. Again, this surprises me. Hong Kong, no. So drilling down a little bit further on anger and frustration as an emotion, maybe it's not overly surprising that of the countries surveyed, Australia, US and French citizens felt the most frustrated, while the least frustrated were Vietnam, China and Indonesia. So I'll leave it there, David. I'd urge people to have a look at this. It's quite a detailed survey, lots of interesting information through it. The references are there. And thanks again, David and Alex, for sending me this. Back to you, David.
Thanks so much, Dale. We appreciate the update. It now leaves me to thank our two experts, Professor Alex Cook for an excellent review of modeling, and Dale Fisher for his usual excellent job. We will have our speaker next week will be Leo Yi Sen, who's Professor of Medicine at National University Singapore Yong Loo Lin School of Medicine, Senior Consultant in Infectious Diseases, and Executive Director of the National Center for Infectious Diseases. Title of her work will be, her talk, will be Management Protocols and Options and the Research Behind Them, now and in the future. Until next week, stay safe, wash your hands, and remember what the great social philosopher M.C. Hammer advised us, you can't touch this. Good night.